to our first pediatric meeting. Hi, Cheryl. Sorry, I got problems with my internet connection, it seems.
Okay.
Can I go ahead with the intro?
Yes, can we go ahead again? Yeah.
Okay, so sorry about that. So welcome to our first Gecko meeting, or pediatric Gecko meeting of the year. These Gecko meetings are held every Wednesday, and you should be getting notifications once you've registered, which you obviously all have. The Gecko meetings are hosted by the Gastro Foundation of South Africa and initiated by the University of New Mexico. So the comments, please put in the chat questions and comments, and we'll address them at the end. So I want to welcome Celeste. Celeste Kock from Midstream Hospital is a pediatrician who's worked there for a number of years, and in my mind, she's really the expert of intestinal failure in children. Very happy to welcome you, Celeste. They're vexing patients, they're difficult to manage, and we always struggle. And I think to have a center like yours to look up to and perhaps mirror in our own settings, and to have your phone on speed dial will be very useful to everyone. So thank you for agreeing to present today, and we look forward to your talk.
All right. Hello, everyone. Can you hear me?
Yes, we can.
Am I there? All right. Hello, everyone. I want to say thanks to Tim for inviting me to present this evening. I see this is a great opportunity to share with you our experience that we have in our unit. Like Tim said, I am based at Midstream Mediclinic in Pretoria. We have a fairly new unit in terms of intestinal rehabilitation, but I would like to share the experience with you. The talk today is really not on, it's not an academic talk that I'm going to do. It's really just to share what we've been doing and hopefully to get some collaboration going. Cheryl, am I on the right route? Am I sharing? Can you see this?
Yes, I can. We can carry on. Perfect.
Okay, brilliantly. All right, so our experience, really, we've tried to set up on this PowerPoint presentation for you for the last 2 years as our data that we have it. I wanted to start off with just giving some definitions. I'm sure all of us know what this is, but I just want to recap. So intestinal failure is any clinical disorder resulting from intestinal obstruction, dysmotility, surgical resection, congenital defects, any disease-associated loss of absorption, and it is basically characterized by the inability to maintain protein, energy, fluid, electrolyte, or micronutrient balance, or all of the above. And basically, this is a big umbrella term for all of these conditions requiring parenteral nutrition or support, either in the form of intravenous fluid or parenteral nutrition, or in some of our patients, both. Short bowel syndrome is, however, the most common reason we have for our kiddies with intestinal failure. And I'll show you in a little bit what our stats look like. So we know that these kiddies tend to survive much longer in the last few decades. More than 80% of our patients will survive even after very extensive resection in the neonatal period. Some of the criteria that give us the prognosis for these kids, and these are just some of them, the main ones, there are other ones as well, is the age-adjusted intestinal length, so the length that we are left with after resection, whether this patient still has his ileocecal valve, Is the patient's colon still intact? Was it resected? And do we have cholestasis or jaundice on presentation or on receiving these patients to our units? Like I said, there are other factors to take into consideration. These are just the main big ones. In short bowel syndrome patients, most of the deaths that we see are due to associated liver failure or due to sepsis. Whether the sepsis is there because of bacterial translocation, in other words, from the gut as the source, or most often from recurrent line sepsis. And what we see the most is the line sepsis, and then you run out of space for lines, and then you get associated liver failure, and that's why we lose these patients. Death usually occurs within 1 year post-event, whether that be surgery or diagnosis of the patient. So if we look at the NASPGHAN recommendation, so NASPGHAN is, I'm sure all of you know, this is the North American Society for Pediatric Gastroenterology and Hepatology and Nutrition. So they have a lot of recommendations, but I tried to just keep it to the simple ones here. So patients that meet the following criteria should be referred to an intestinal failure program. The need for parenteral nutrition longer than 60 days due to, again, intestinal failure as a whole. And this encompasses intestinal disease, dysfunction, or resection. So if your patient's on TPN for longer than 60 days, you should really be thinking about referring this patient to us. If your patient has less than 25% of expected bowel length left, so this is in the case of a short gut syndrome baby, then you should really be thinking to send to a unit. I think a lot of the units feel that often these are things that they can manage in their unit, but I think at the end of my presentation, hopefully, you'll agree with me that there's really a place for an intestinal failure program. It goes beyond just managing the obvious things that we think we can manage. So if we take an intestinal failure program and we try and apply this to South Africa itself, I mean, there's lots of intestinal programs internationally, North America, Europe, but if we just look at South Africa, we have a lot of questions, we don't have a lot of answers. How many children do we have in South Africa that suffer from intestinal failure? What is the pathophysiology of these intestinal failure? How many of them are shortcuts? How many of them have malabsorption? How many of these patients have gone through some sort of program and have attained enteral autonomy? So we were able to wean them off parenteral nutrition, wean them off IV fluid. How many pediatric patients are actually on home parenteral nutrition? And as far as my knowledge goes, I'm not aware of another unit in South Africa that does home parenteral nutrition in pediatric patients. I think there is a unit in Cape Town that does adult parenteral nutrition. And I know the unit that's probably most experienced is Pretoria Hospital in Cape Town, but I'm not aware that they've got a home TPN program. And like I said here, how many intestinal failure programs in South Africa? Like I said, the only ones that I'm aware of is ourselves, and I think Pretoria when it comes to pediatric patients. So then having a look at intestinal rehabilitation programs, we have to go and look at the international data and statistics that we have and the data that we have. And what we know is that an intestinal failure is a debilitating condition that presents with acute and chronic medical challenges. These programs exist North America and in Europe. In South Africa, we have a problem when it comes to this. What is new? So the management of intestinal failure by an intestinal rehabilitation program is the current state of the art, with limited but highly encouraging supportive data on medical efficacy. So when these programs exist, we should be referring to them. There is data for it. NASPGHAN endorses the management of patients with intestinal failure or in consultation with centers with these programs, and it encourages the further research on the medical efficacy, patient satisfaction, and quality of life, and obviously the financial impact on these programs because it is immensely costly. So the importance of intestinal rehabilitation programs. Achieving enteral autonomy in these programs have been related to longer relative or absolute bowel length. It's been proven. all care at a specific intestinal rehabilitation program center and surgical bowel lengthening were also predictive factors. And then they've done a consortium of 14 different centers did a study on 172 children. And they concluded that achieving enteral autonomy was definitely associated with the diagnosis of NEC, lower bilirubin levels on admission, longer residual bowel length, preserved ileocecal valve. I've mentioned all of these factors before, and care at a non-transplant center. So in other words, an intestinal rehabilitation program. So the role of this program should then be to be regional, national, or an international referral center that can provide comprehensive, safe, state-of-the-art care to improve the survival and the quality of life and minimize the complications, obviously, of these intestinal failure patients. It also is there to promote intestinal adaptation, because that is at the end what we want, because you will never get enteral autonomy if you do not have intestinal adaptation. We obviously want to decrease morbidity in these patients as well. So what is the process of establishing such a program? We obviously have to establish that there is, in the first place, a need for these patients and identify the services that have to be rendered to these patients. I think that is definitely something that we have done at Midstream Mediclinic. We definitely see a need for having a program for the patients that are referred to us, but I do still think that we're not getting the referrals. I'm not sure if people are not aware of the program or what we offer as services, but the need is definitely established. We have to establish the different components of interest related to the diagnosis, surgery, and then as well transplantation, which we do not offer. We are trying to liaise with Donald Gordon, as you know that they are a transplant center, and we are liaising with them when it comes to the need for transplantation for our patients. We have to have a business plan and a budget. As you know, we are a private institution. We are not a state institution. So at this stage, medical aids and funders play a huge, big role and determines what we can offer to our patients. We are not able to offer the service to any state patients at the moment, which is very sad, but I'm hoping to spark some motivation or enthusiasm somewhere and to see if we can get collaboration going. We need to objectively demonstrate the success of our program early in the development to make sure that it will survive. And we have appointed someone to collect data and stats for us. And you can see at the bottom, this is we collect this and even more medical and surgical history, the current anatomy of the patient, diagnostic tests, the surgical procedures, nutritional assessments, the complications. We collect all of this. And I think with what we have for the last 2 years, we can already demonstrate the success of our program. All right, so who should the members of the intestinal rehabilitation team be? You can see it's quite comprehensive. I don't know if they think that the pediatric surgeon is the most important one of the team, but he seems to be first on the list every time. Yeah, and to be honest, we will not be able to manage without our pediatric surgeon at all. So let's leave them at the top there. So pediatric surgeons, transplant surgeons, definitely a part of the team. We don't have that service to be offered at our unit. But like I said, we are collaborating. We need pediatric gastroenterologists, the neonatologists, or the ICU team. We have specialized nurses, or I call them TPN nurses in our unit. We have dedicated pharmacists. We have to have dietitians, social workers, occupational therapists, speech therapists, child life specialists, which we don't have in our unit, psychologists, medical educators. So you can see this is quite an extensive list of who makes up this team, and it takes quite some time to get the right people invested in this program. I'll be getting back to who we have on our list and our team at the moment. So this is our hospital in Pretoria. We have an established failure unit that's been running for the last 2-3 years. I'm not sure some of you might recognize some of the names on our list for the South African colleagues that are watching. So our pediatric surgeon is Dr. Paul Stevens. We have 2 pediatric gastroenterologists. It's myself and Dr. Leslie Hendricks. We have our ICU team currently also comprised of 2 doctors, Dr. Morar and Dr. Jones. We have a dedicated intervention radiologist team. We have dedicated parental nutrition nurses, and we only have 4 of them. We make sure that 2 of them are on duty during the day and 2 of them are on duty during the night. And there's always 1 of them on call, literally every single of every day, because we do not allow any agency staff or untrained staff or staff from other hospitals to change our TPN lines. Those names that you see on the list there, those are the sisters that change our TPN. And we have had great success in terms of infections, complications, you name it. We really have good success. And I think it's because we stick to certain protocols, and things that only get done in a certain way by these specific sisters. We have a dedicated pharmacist, Annika. She works very, very, very hard because we have 11 home TPN patients that come and fetch their TPN on a weekly basis at the pharmacy. We have had to split them up. They come on Tuesdays and the other group comes on Saturdays because the fridge cannot manage all the TPN. It's too much. Every patient fetches 7 bags every week. So yeah, it's about 77 bags per week. So a lot of hard work, a lot of dedication there. We have 2 trained registered dietitians. We have our team of occupational therapists and speech therapists who are brilliant. And we've just spoken to a big group of a psychology group called Evexia that is based at Midstream Mediclinic. And they'll be offering a lot of support to the parents themselves who have gone through a lot of trauma, even on pre-referral to us. And then to prepare them for the way forward, there's a lot of psychological support that they need. Often we need to get a social worker in as well. We have a unit coordinator, Nadine Pretoria, who's actually one of our mothers. She's got a lot of insight into what is needed by the parents themselves, and she also collects our statistics for us. And then obviously the transplant surgeon, like I said, based at Wits Donald Gordon. That program is not completely established yet in terms of intestinal transplantation, but I'm hoping that things will start going or start happening somewhere in the future. So this is our team. We are extremely, extremely proud of our sisters that are doing an amazing job in the ward. We have 20 beds in our ward, 9 isolation beds. We have 1 twin room, 2 beds in a twin room. And we have 3 bays with 3 beds. We are very capable of giving TPN over long periods of time in the main pediatric ward. We don't need to put these kids in a high care or a pediatric setting. Like I said, our sisters are extremely capable, and we've done this numerous times before we had our ICU established. So we are very, very lucky in the fact that we got a very brand new ICU in August 2022. It's a 6-bed unit. We've got a big boardroom where we can do training, and this is obviously where we collaborate and we sit down and we talk about the unit and we talk about stats, and we do a bit of collaboration. So if we get to the stats, and this is actually the important bit for me, it doesn't look like big numbers, but I do think you have to realize that we are still a very, very brand new unit in terms of comparing us with units internationally all over the world. We are really still in the baby phase. We have a lot to learn, but we're just starting out. So we have a total of 38 patients. Actively managed, we have 24, of which basically almost half are home-based TPN patients. Inactive, we've lost about 14 of our patients. 8 of them were lost to follow-up. This is where they would come and see us once off. Usually they are a bit older, 4 years old and so on. And they come and see us and they just can't see their way of being admitted and doing all the rehab again, and they don't come back. We've lost 3 patients already, 1 ultra short bowel sepsis, a lot of electrolyte abnormalities, and we've lost 2 due to bacterial translocation and sepsis. 3 of our patients have moved back to other provinces, and we are liaising with their doctors on that side. So this is our etiology. As you can see, NEC is really our main leading cause for our intestinal failures. We have 4 patients with gastroschisis. We have 3 patients with dysmotility, and under dysmotility, we have 2 patients with hollow visceral myopathy and one with degenerative leiomyopathy. One of our patients have subsequently turned 18, and he's been transferred to our adult colleagues in the last year. 2 intestinal atresias, 2 patients with malabsorptions. These patients have primary immune deficiencies, quite severe, A-gamma globulin anemia with complete total villus atrophy and malabsorption, and they are very, very much TPN dependent for nutrition. We have 2 intestinal volvulus patients, 1 patient with cystic fibrosis, and then funny enough, we have 2 patients with unknown etiology, bowel removed, and we don't have the etiology for that. So yeah, we obviously cannot compare with any other units in South Africa. We just don't have the statistics, we don't have the data, so we have to go to international figures and compare ourselves with them. As you can see, it's quite an old article, but it was written by one of the leading professionals in the world when it comes to pediatric intestinal failure, Prof. Golay. And as you can see, all over the world, whether you look at France or Canada or the USA or even other international countries, NEC seems to be the main contributing factor when it comes to short bowel syndrome specifically. And if you then take our statistics and you compare it with what is out there internationally, we are right on par with NEC being the main leading cause. Our numbers are fairly high, but our numbers are, it's still early. We're only 2 years in collecting the data, so the picture might change, but I think you can agree with me, NEC clearly stands out from the rest of the other causes. This is just to put this in a visual graph for you. As you can see, NEC by far the most common reason we have for our intestinal failure patients. If we then just have a look at our home parental nutrition patients, not the whole cohort, not all of the active patients, just the home TPN patients. We have currently 11 home TPN patients. This is the spread of the etiology that we have in them, and you can see again NEC and dysmotility right up there. And then second, we've got malabsorption and volvulus, 1 Hirschsprung's patient still on home TPN. We haven't been able to wean off any of these little patients yet. If we look at the complications, and this is by no means a full spread of the complications that we do see. I've just taken these few and put it on a graph. And as you can see, small bowel bacterial overgrowth is really the main thing that we really struggle with. And the difficulty is that each patient then presents in a different way. They all respond to a different antibiotic. The one patient will respond beautifully to a flagell course, the other one needs Augmentin. Yeah, so definitely the bacterial overgrowth is our main thing. Our parents are really very well trained. They recognize the symptoms very, very quickly, and they can contact us and say, listen, my child's got bacterial overgrowth. Will you just send me a script, and we can still manage these patients at home. They don't always have to be admitted with diarrhea or vomiting or bloating or gas. Our second biggest issue with our patients are CAPSIs, so line infections. We've only had 10 line infections in the last 2 years, which I think is really not a bad number if you think about it. And these patients are at home as well, being managed by the parents themselves. We have one patient that's very interesting. He presented with a D-lactic acidosis. He's the only patient we have in the whole cohort that presents with this. Basically presents with severe metabolic acidosis and gets neurological symptoms, gets all completely encephalopathic, and then that needs to be managed fairly urgently in the ward. I do think that when we look at bone disease in our patients, we are underestimating the amount of bone disease that they've got. I'm still trying to get around to the correct way of testing them. As you know, doing DEXA scans in the very young patients, it can be quite tricky to interpret. So we are busy getting around that protocol of ours, but bone disease definitely is an issue that we are underestimating in a lot of our patients, and I think a lot of people are not even looking for it. We have, funny enough, the same patient with D-lactic acidosis also had kidney and gallstones. We see a lot of vitamin deficiencies. When I say a lot, we've got 6 different patients we see vitamin D deficiency is the first one that pops up. And then we've also seen a lot of vitamin B12 deficiency due to loss of terminal ileum, which we then have to supplement intramuscularly. And the other thing that I think we grossly underestimate is liver fibrosis or cirrhosis or liver damage in our intestinal failure patients. I think we miss it because the blood work looks okay, but we don't do liver biopsies in every single patient that we have. It's invasive. We don't always think it's necessary because the blood work looks fine and our patient is not jaundiced. However, we are currently looking at a program of screening some of our patients and doing routine liver biopsies in some of our patients, just to be able to make a note to say this patient does have advanced liver cirrhosis or fibrosis. We probably should be referring them to Donald Gordon early for an assessment, just to get them in the program on that side as well, so that we can collaborate about further management for these patients. So other complications that we have with Proviax, it's not just infections. So yeah, our kiddies are really busy sometimes. They don't want to be connected to lines and be stationary in one place. So they break their lines at sometimes, and it's usually at 10 in the evening or midnight, or it's usually an urgent matter. Luckily, Dr. Stevens is very good with repairing these lines, and you do get a kit and you can just fix it. We don't have to remove the lines all the time. But as you can see, we've had 6 broken and repaired lines. Like I mentioned before, we've had 10 infections, and we've had 4 of the times we've had lines that have blocked, where either we by mistake ran iron intravenous and in a Proviax line, and it blocks our line. And yeah, so we've had some few incidents like this, but that's how you learn. If we look at what we've been growing, as you can see in our unit, definitely Klebsiella is the main organism by far. We've had one staph, and we've had some strep and E. coli. And then obviously sometimes you don't grow anything on the line, but you know that it's a line infection. But at the moment, Klebsiella is our first go-to. So we usually, when we think about our empiric antibiotics, it is to cover the Klebsiella. If we look at parental nutrition, I'm sure all the other units, when they do use TPN, we are very fortunate to be able to have SMOF-lipid. Using SMOF-lipid, you all know it has its advantages in our patients, being anti-inflammatory and all that. We have identified quite a big gap in the current TPN solutions that are available to us and our little patients, because it only serves up to the age of about 10 years. And once our patients get to 10 years and up, the biggest pediatric TPN bag, which is the 9330P, does not meet the nutritional requirements of those patients. And we can't use the adult TPN bags in them because, the copper and stuff like that would be liver toxic to those patients. So the gap was identified. Our dietitians have really collaborated with Fresenius Kabi, and they've made us a new TPN bag. It's called 9381P, and very nice TPN bag that we now use in our kiddies from 10 years up to 13, 14 years. And then obviously when they're older than that, they can go onto the adult bags that can then be used. We obviously have some shortcomings and we have challenges. I think transitioning our patients to the adult service it's difficult, and it's not an easy thing in any chronic illness, especially in these kiddies. I think we tend to struggle to let go. And I also don't think our adult colleagues necessarily want to take these patients because they are complex. Our adult colleagues are not necessarily as invested in this as we are. And to be blunt, I think we've been blamed many times that we baby our patients in the pediatric population. So it is a difficult thing to transition them to adult service. I'm still trying to figure out how to, maybe establish a clinic and to find time in a private practice, both doctors having a clinic, sitting down with a patient. It's not an easy thing to do, but definitely not impossible. So that is on my to-do list to get this established. We've already transitioned one of our 18-year-olds to adult service. And this is Jamie in the poop suit that you can see. He's probably going to be our next patient that has to be transitioned, but we've probably got about 3-4 years before we get to that point. Transplantation service, as I mentioned, not available at our unit, but we are collaborating with Donald Gordon. We can definitely do liver transplantations there. Whether we will be in a position to do intestinal failure and liver transplants, we'll have to see, as time goes by. Another huge big headache has been the funders, because the insight of what intestinal failure is, what it entails, really has been very challenging at times. The motivations that we have to write to get them to understand what is needed has really been challenging, but we've overcome the challenge. And like I said, we've got 11 patients on home TPN. It's definitely doable. We've had to go to the Council of Medical Schemes with a few of our patients. I don't think we've lost a case so far, but yeah, it's very challenging. It's very costly. And obviously the funders look at cost, and it interferes with decision-making as well. Palliation, a big component of our unit. As you know, that there's a big palliation service from our Cape Town colleagues. They offer a palliation course. We are planning to send a few of our colleagues in the program to do that palliation course, because we are not able to save all of our babies. Some of them has to get palliation. So there's a big part of what we do as well. So yeah, just a shout out. I always say all of our kiddies are superheroes, but not to forget the parents. We have to remember that this is a big lifestyle change for the whole family. These kids go home, they have to be on TPN anything from 13 to 20 hours a day. The parents have to change these TPN lines. They have to do it in a sterile fashion to prevent complications. And we have a few of our kiddies that actually go to school. So they come off their TPN, they go to school, they come back, they are reconnected, and they continue with the program. So amazing people. It's not easy, but it can definitely be done. Yeah, and these are some of our kiddies. We're very proud of them. They've done really well. And thank you so much for watching.
Thank you so much, Celeste. That was excellent, and I'm really impressed with the unit you've built and the service you're doing. It's awesome.
Thanks, Tim.
So I don't see any questions in the chat yet. I was wondering, the few that I've been involved in very peripherally, in terms of short bowel or intestinal failure, I should say, the impression that I've had always is that they're referred very late to a program. I mean, obviously we don't have your type of program in the state, but it seems that they're either referred late. I think they also seem to give up on patients quite quickly. Yes. When, you know, if they do a laparotomy and there's 30 centimeters of bowel, are you going to do the resection, or are you going to close up? So I don't know what your experience with that is, and what's, you know, the sort of difference between state and privates.
So I think in our experience anyway, our patients get referred sometimes very late. You know, I think a lot of centers are not aware that there is a program available somewhere that you can send these patients. And in other instances, they get referred, you know, once we start struggling with lines. Once the doctor's not able to insert a line, then we need to send it along to the unit. The problem is that we then also struggle with inserting lines, and it really limits what we can do then for the patient. So we've really been advocating for units to send earlier, to follow the guideline of TPN more than 60 days, please refer. Because if we have line access, we can do so much more for these patients. But yeah, I do think it's not an easy decision to always decide, are we just going to do palliation on these kids? Is it worthwhile sending this baby that's got 15 centimeters of small bowel? You know, the prognosis is so bad. Are we really even going to send this patient? So we also don't just take any referral. We sit down as a team. We've got a referral form that we send to the referring unit. They fill it in for us. We want to know where the line axis is, how many infections have this baby have, is there cholestasis on board? And then we would sit down as a team and go through everything and decide, listen, is this is this futile, or is there potential? Can we take this baby? So it's really not an easy decision to send or to receive these babies, but that is why we have the unit. So we tend to take them most of the time and see what we can do for them.
Yeah, I think next time I'll give you a call, because it's not easy to advise whether things are futile or not. I've got a comment from GH, but I actually think it's Chris Cassianidis on the Gastro Foundation. He says, great program, congrats. The question is, why not screen for cirrhosis with the APRI score? It's less invasive than a biopsy.
And Tim, help me out. Do we use the APRI score in pediatrics?
Yeah, we do, but it hasn't been shown to be very specific, is what I understand. Yeah, so I think, I don't know if that's very different to adults, but certainly in kids with portal hypertension, it doesn't have that much predictive value in terms of varices and that. Sorry.
I can probably do a bit of my homework and just read up and see if maybe this is something that we can do in our patients. If it is, then thank you for the suggestion. But I'll have to read up if it's really as applicable in the pediatric population or usable in the pediatric population as it is in the adult population. If it is, it would be great to have a look at it.
Yeah. There is another question from Everestus Chukwudike, who says, do you have facility for transient elastography? And same sort of line, do you consider the other non-invasive markers for liver fibrosis rather than routine biopsy, considering the complications?
Yeah, we don't have it available in our unit as far as I know. I can definitely double check, especially for the liver fibrosis. It would be amazing not to have to put in a needle into a child. As far as I know, in our unit, we do not have the elastography available. So that's definitely not something that we can use. In terms of the other markers, we definitely look at them. I mean, you look at all the markers for compensated liver disease and you look at the markers for fibrosis. There are, however, in intestinal failure, some of the markers get skewed a little bit, especially if you look at, this is probably most applicable to cirrhosis, but if you look at your INR, it's not very effective to use in your intestinal failure patients because they get high INRs for different reasons. I haven't really come across a non-invasive way of really doing or establishing if our patients have cirrhosis or fibrosis. Like I said, we haven't even established a proper protocol. We've just recently decided that we should probably be looking at this to see, because I think we are missing a lot of our patients. We haven't been doing the intestinal biopsies or the liver biopsies yet because it is invasive, I agree. We'll look at the different markers that are available. But at this stage, we haven't been using anything at this so far.
Yeah, thanks. There's a hand from Sianda, but just to also maybe ask Dr. Birkenfeld what the experience is at the liver transplant unit in terms of elastography in pediatrics. Sorry to put you on the spot, Sarah.
Sarah.
Oh, okay.
No. We don't tend to use transient elastography at all with our patients. From my understanding, and again, I can stand to be corrected, but there isn't evidence-based normal values for transient elastography. So when it comes to assessing, I suppose we're a bit of a skewed practice because we kind of always get them when they're obviously cirrhotic and they need transplant. But to assess like the fatty livers or the NAFLDs and the NASHs and the intestinal failure associated liver diseases, we haven't used transient elastography, and maybe it's something that we need to think about doing. But my understanding is that we don't have evidence-based normal values in the pediatric population.
Pediatrics.
Yeah.
Thank you, Sarah. Sianda, please go ahead.
Hi, thank you for a great talk. I just have two questions and maybe they are related. The first one is, I would have thought that, as the kids get older, that there is some growth in the intestines and you would be able to get some, let's say, off the program in that way. And then the second part is in terms of intestinal, because it's difficult if you don't have access to intestinal transplant, but in terms of intestinal lengthening procedures, what would be the best sort of time to do those? Would you wait for them, to get past adolescence and assess, let's say, when they've finished growing?
So, yeah, I'm not going to make any comments about the intestinal transplant. I really don't think that is something that is available in South Africa. Anyway, I'm not aware of a unit that's done an intestinal transplant on a child. Definitely not at Donald Gordon while I was there, and I don't think anything has happened since I've left, Sarah. But in terms of what was your second question? Yeah, your intestinal, the lengthening procedure. We definitely, some of our kids get referred to us and they've already had the step procedure. So many of these kids, by the age of 3-4 months, they've already had step procedures done by the referring surgeons already. We have had some tapering procedures done in our unit. So when the intestine really bloats up and it gets really big and malabsorption starts becoming a problem, the tapering procedure actually it really helps. Obviously, they can just blow up again and you have to redo the tapering again. With regards to the best timing of doing this, I'm not a surgeon, so I don't do these procedures myself. I usually rely on Dr. Stevens to give me some guidance for this, but we actually do them fairly early on. The tapering procedures takes time. Obviously, it takes time for that gut to dilate and become dysfunctional and have a dysmotility, and then you do the tapering. But the step procedures get done actually fairly early on already to try and get extra length and get extra absorption area. So, but yeah, obviously we do get some of our patients off TPN. Like you said, we've got about 38 active patients, and we've been able to wean, how many, 30, 11, more than half of them off TPN. So definitely with time, the bowel adapts. The best adaptation that you're going to get is in the first 2 years of getting these patients. So if we get them at 1 year of age, we've lost a whole year of possible good adaptation that could have happened. So yeah, we can get all of these, most of these patients we can get off. It's just our ultra short guts probably going to be on it lifelong.
Yeah. Okay, thank you.
Great, thank you. I think you also, for the step procedure, need a little bit of dilated bowel to have more surface area to work with. But I know it's generally done quite early. I don't see any other hands or comments or questions. Giving you 5 seconds. No one's got a question. 3, 2, 1. Thank you so much, Celeste. It was really an excellent talk. Like I said, I'm really impressed by you and your unit and what you've achieved. So thank you very much for sharing with us. Also thanks to iEcho University of New Mexico and the iEcho India team. They do the technical stuff. There will be a feedback form available in the chat, so please feel free to fill that out. And then the recordings will be available on the Gastro Foundation website. Thank you also to Cheryl and Karen and Chris and the Gastro Foundation for the opportunity. Thanks to all the sponsors. And then for next week, I think Dr. Burnham and Dr. Joshua Human are going to speak about vascular complications of cirrhosis and HCC. So we hope to see you there. Thank you very much.
Thanks, Tim.
Thanks, Celeste. Very excellent. Thank you.
Thanks, Chris.
Cheers.
Bye-bye.